If you have somebody who's got chronic pain, which I see a lot of, things that factor into my decision is, do we know that the pain is stable? Okay, that's the first question I ask. So if somebody comes in, they have a chronic pain diagnosis, I have chronic low back pain, my doctor wants to get me a TENS, I won't dispense a TENS until we have a conversation. Have you had physical therapy before? Who have you been evaluated by? What types of activities can you do? If they've never been to a physical therapist before and they've had back pain for 3 years, and as I do my examination, if I see mechanical components to their pain, I may wait on a TENS unit because I may want to start creating a sense that, you know, you can fix this, improve this from where it is. You're not at a management phase. You're actually in a rehab phase. And we're going to work on rehab first, see where we go, and then we can manage what's left. Right? And that would always depend on the severity of their symptoms. So I have patients who come to me with diagnosis of chronic pain who have never seen a physical therapist. Never. And they're told that they just have chronic pain and they're just going to have to deal with it. I find that remarkable. So if I get one of those, rarely would I go to a modality right away. I would keep it in my back pocket for a reassessment. So if they don't progress, if I in fact thought they were a rehab case and they're not able to improve in any way for whatever reason, then I'll shift back into the management piece. So I always looked at, is there stable and what's the source, right? If the source of your pain is some localized inflammation from overuse, I'm not going to go to a TENS unit for pain management unless it's really high, right? If they can't get any relief, and some people, for whatever reason, cannot or will not tolerate medications for pain or choose not to take it, I may select a modality for pain if they don't have any other options and the level of acuity is high. But those are kind of the decisions that go into that. So with the electrical stimulation indicated, that's just strict impairments. Do they have a loss of motor function? Do they have a pain condition? Do they have a muscle spasm? Do they have muscles that are firing incorrectly due to injury or neurological conditions that may need some re-education? Have they had a surgical intervention which disrupted the joint and the receptors in the joint, which has now altered how muscles fire with respect to one another? Do they have swelling? Those are the impairments that I'd go through. And all those is electrical stimulation indicated, and then can it be used? You're looking at your contraindications.
Are we ever going to make, as a PTA, are we ever going to make the decision as to if we use the Estim or the TENS or the...
Yes.
We are. We're not going to be told which one to go use.
Right.
We're going to make the decision.
Right.
Okay.
Scary? It's okay. Yes. So you can use this tree. My job is to go through, look at the contraindications. So one, is it indicated to make the decision? Can you use electrical stimulation? Electrical stimulation. Can you use it? Yes or no? And then I base that decision on whether or not they have contraindications, first of all. And then after speaking with them, I always ask, have you used this before? Because nothing's more embarrassing than saying, I'm going to use this great thing, it's called a TENS unit. I'm saying, I tried that, it didn't do a darn thing for me. Without asking ahead of time. So I'll ask, have you used something like this before? Yes, I have. Did you find it helpful? No, I didn't. Tell me how you used it in the past. It may have been an error in how they were using it that made it not effective. So I have those types of follow-up questions. So can electrical stimulation be used? That's the contraindication piece. Those are your red flags. So the physical therapist will do those for you first. Is it your responsibility to know what those contraindications are? Yes, because we talk about how patients will disclose things in treatment that they didn't think was relevant. They filled out so many papers that they skipped the part that they had a history of melanoma on their skin, and because they're coming for their knee and they didn't think that was important. And then we go to what's the therapeutic goal. And that always relates to these, right? So your physical therapist has gone through the list of impairments, and from that list of impairments has generated some goals. So if I go to the stroke case, I would say I want to increase the strength in the left ankle dorsiflexors. I'm just going to abbreviate to, and you haven't learned strength grades yet, so just don't worry about this one. 3+ out of 5 in 2 weeks. Okay. So I wanna do that. I wanna make sure I have a measurable change in how much that patient can lift their foot up, and I think that neuromuscular electrical stimulation could help with that. So that would be a therapeutic goal. So if you see this goal, a strengthening goal, and you see Estim, you should be able to select which box does that. Okay? And that's where you have the list of choices here, the EMS, the NMES, the FES, the TENS. You should be able to look at this goal and select the intervention. Select the modality, once the modality's been put on the list of choices. And then everything else is up to you. Everything else, once you make that selection from these bullet points here down, is within your scope of practice. So these are things that you would choose, okay, well based upon this, what sort of clinical stimulation am I looking for? Subsensory, sensory, motor, or noxious? Not noxious. Are we trying to affect the sensory system or the motor system? Motor system, because we're trying to build strength. So we're trying to affect the motor system, and then what sort of waveform are we going to use? Does polarity matter with this type of situation? In terms of, you know, the positive, negative poles matter with strengthening?
No, because you're not.
That's right, Joe, does polarity matter in neuromuscular electrical stimulation?
Well, honestly, what I pick up in the field is it really varies. I would say that realistically on day to day, I don't see therapists following that. That doesn't mean you're not gonna find it in a textbook saying this is what you should do and switch polarities and whatnot, but
Right.
I don't see therapists
Right.
really paying attention to
Right.
that.
So to get a tetanic muscle contraction, polarity is not really a deciding factor in that. Right? Wound healing and edema management has a different mechanism of electrical stimulation, so polarity makes a difference. Yeah.
I'm glad you brought up wound healing. Will we actually be performing that?
It is in your scope of practice and it is on your examination. There are, in this region, there are very few physical therapists who do wound care. However, there is someone locally who does it who will be instructing, and you will learn how to do what's called debridement, which is cleaning the wounds. What is outside of your scope is sharp debridement, so you don't get to use any little scalpel-like devices to clean a wound. But yes.
Because in the book, to me at least, it was kind of confusing if it was, you know, successful or not. You know, a lot of times it says, oh, well, this and this and this did this,
Right.
and there's no really
Right.
documented
Right.
proof of it.
Right.
And the whole chapter seemed like that.
Well, luckily we have somebody in the area who's going to do your instruction next year when we go into that. So he will be able to give you some more information as to what he does for wound care. So it's an adjunct to the entire process of wound care. It is not the thing that causes the wound to heal. It's a tool for that. So then you choose your unit. So you would choose your unit for what you want to do. And then delivery, simultaneous or reciprocal. So in this situation, for the muscle stimulation, am I looking for alternating movement? And am I trying to do some re-education where I'm turning on an agonist and then turning on the antagonist? You know, if he's got normal calf strength, probably not. You know, if he's got maybe some weakness in the calf as well, I may have the foot go up and down, so there's an alternating motion there. The current characteristics. So if you want to stimulate someone's muscle and you want to get a big contraction in a hurry, you're going to change your RAM time accordingly so the signal goes right up and you get that tetany as soon as possible. Someone who's having maybe more pain or discomfort or has more altered sensation, you may have to ramp up slowly so you can monitor their tolerance to the electrical stimulation. It can feel weird and sometimes noxious to folks, so that may play into your ramp time decision. Whether or not that muscle is going to have endurance on a cellular level. So there are some conditions where if you overstimulate, you can actually create more problems.
In re-education, would you use a longer ramp time?